Hello, my name is Elizabeth. Is your heart too slow? The 2018 ACC-AHA guideline addresses bradycardia and conduction delays. It focuses on practical clinical evaluation, not exhaustive reviews. Sinus node dysfunction and atrioventricular. Block myopia are key areas, often needing treatment. Age, sleep issues, and medications can be causes.
Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
All right, get ready to dive deep into bradycardia today.
Sounds good.
You sent over some pieces from the 2018 ATH-ADRES guideline on the evaluation and management of patients with bradycardia and cardiac conduction delay.
Yeah.
And it's dense.
It is a dense document.
But we're going to break it down for you.
That's what we're here for.
So you walk away feeling like you know what you're talking about.
Exactly. We're going to give you all the key takeaways.
Okay, so bradycardia, we all know the textbook definition, heart rate slower than 60 beats per minute.
Right.
But is it ever that simple?
Never that simple.
As anyone in medicine knows, it's rarely that straightforward.
Absolutely.
It depends, right?
It does depend a lot on the context.
Context is everything.
Like, a young athlete
Yeah.
might have a resting heart rate in the 50s, and that's totally normal.
Totally normal.
Healthy heart.
Versus that same heart rate in an elderly patient with heart disease.
Yeah. That could be a huge problem.
That's a serious problem.
Huge red flag.
So we've got to think beyond just the numbers
Yeah,
when we're thinking about bradycardia.
for sure.
So one that jumped out at me in these guidelines was sinus node dysfunction, SND.
Yeah, SND.
So can you break down for us exactly what's happening in SND?
So the sinus node, as you know,
The sinus node.
it's our heart's natural pacemaker.
It is?
It initiates those electrical impulses
Uh-huh.
that make our heart beat.
Yeah.
And so in SND, the sinus node isn't working properly.
It's malfunctioning.
Right. And it can manifest as a few different things.
Okay.
It can be a persistently slow heart rate,
Yeah.
sinus bradycardia,
Sinus bradycardia.
or it can be intermittent pauses in the rhythm,
Pauses.
sinus pauses, or even sinus arrest,
Oh, wow.
where it just stops for a moment,
Yeah, that sounds scary.
which can be very problematic.
So the guidelines have a really helpful algorithm
They do.
for evaluating suspected SND. And they also go over some of the possible causes. Some of them make a lot of sense, like aging,
Right.
coronary artery disease.
Aging, heart disease in general.
But I was surprised to see sleep apnea in there.
Oh, yeah.
What's the connection there?
Well, so in sleep apnea, you're having these repeated pauses in breathing,
Yeah.
right?
Uh-huh.
And this puts a lot of stress on the cardiovascular system.
Yes. Yeah.
And that stress can lead to all kinds of rhythm abnormalities,
Makes sense.
including SND.
That's a good reminder for all of us to think about the whole picture.
Yeah, right?
The whole patient.
When we're thinking about these things.
Absolutely.
Not just the one thing
Right.
in front of us.
The heart doesn't exist in isolation.
So the guidelines also talk about treating SND.
Uh-huh.
And they talk about permanent pacing as an intervention,
Right.
but it's not always the first line of defense, is it?
No, it's not.
We always want to try and fix what we can fix first.
We always want to address reversible causes first.
So if sleep apnea is contributing,
If sleep apnea is the problem,
we want to treat that first.
treat the sleep apnea, see if the rhythm improves.
Hopefully that takes care of it.
And then they also have guidance on choosing what kind of pacing
Yeah.
to use, which is helpful because
there are a lot of options.
it can range from single-chamber atrial pacing to dual-chamber pacing.
Exactly. It all depends on the individual patient.
So individualized treatment plans.
Always.
That's what we talk about on the show all the
It's the
time.
best medicine.
All right, so let's talk about another type of bradycardia
Okay.
that can really throw a wrench in things.
Sure.
AV block,
AV block. Yeah.
atrioventricular block.
That's the one.
Can you walk us through what's happening electrically
Okay.
when we see AV block?
So in AV block, the electrical signal is disrupted between the atria,
Okay.
the top chambers of the heart,
The top chamber.
and the ventricles,
Uh-huh.
the pumping chambers.
Yeah, the pumping chambers.
So the signal from the top to the bottom
Yeah,
is messed up in some way.
messed up.
And it can range from a slight delay,
Okay.
which we call first-degree AV block,
First degree?
to a complete blockage,
Oh, wow.
which is third degree, or complete heart block.
So it's like a spectrum.
A whole spectrum of dysfunction.
And this is where the ECG becomes really important to
Critical.
interpret. Right.
Critical.
So you mentioned first degree AV block.
Yeah.
What does that look like on the ECG?
So in first-degree AV block, what we're looking for is a prolonged PR interval.
Okay.
So the PR interval is the time it takes for the electrical signal to travel from the atria to the ventricles.
Yeah.
And normally that's less than 200 milliseconds.
Okay.
In first-degree block, that interval is longer.
It's stretched out.
It's consistently longer.
So there's a delay.
There's a delay.
Yeah, it's like a traffic jam on the electrical highway.
I like that.
But the signal still gets through.
Eventually.
What about second-degree AV block?
Okay, second degree.
This seems more complicated.
Yeah, it gets trickier. In second-degree AV blocks, some of those atrial impulses, they don't make it to the ventricles.
They don't get through.
And that results in dropped beats.
Drop beats, okay.
And there are two main types.
Okay.
Mobitz type I and Mobitz type 2.
Oh, the Mobitz types.
Yeah.
Always a favorite on cardiology exams.
Every cardiologist's favorite.
Can you break down the difference for us?
Sure.
What's the difference between those two?
So Mobitz type,
I.
also known as Venkabach.
In Quebec.
In Venkabach, the PR interval progressively lengthens with each beat.
Okay.
Until a beat is dropped.
So it gets longer and longer and longer.
And longer and longer.
And then drops.
And then drops.
And then starts over.
And then it starts over again.
So it's like someone trying to push something really heavy uphill.
I like that visual.
Right.
Yeah.
Like they're struggling.
Play more and more.
And then they have to take a break.
Got to take a break.
And then start again.
Start over.
So there's a warning sign, right?
There is a warning.
With Mobitz type.
Yes, that gradual lengthening.
Gradual lengthening.
Before the dropped beat.
But Mobitz type 2 is different.
Mobitz type 2 is sneaky.
It's more sudden.
Yeah, unpredictable.
So the PR interval is constant.
Constant.
And then boom, drop beat.
Out of nowhere.
Roadblock on the electrical highway.
Exactly.
A sudden roadblock.
Okay.
And Mobitz type 2 can be more serious.
More serious? Why is that?
Because it often indicates that the block is lower down in the conduction system.
Lower down. Okay. So Mobitz first, gradual. Mobitz tent, sudden.
Surprise.
What about third degree?
Third degree.
What happens there?
So in third degree AV block, there's a complete disconnect.
Oh, wow.
Between the atria and the ventricles.
So they're just doing their own thing?
They're doing their own thing.
Hardly separate.
They're beating independently.
Okay.
The atria are doing their thing, and the ventricles are doing their thing.
At different rates.
Much slower rate, usually in the ventricles. So it's like two different drummers trying to play the same song.
But completely out of sync.
Totally out of sync.
Doesn't sound good.
It can't be good.
It's not good for the patient.
It's in a life-threatening situation, potentially.
It can be, yeah.
The ventricles slow down.
Dangerously low rate.
You can have dizziness.
Dizziness, fainting.
Fainting.
Even cardiac arrest.
If it's not treated.
So speaking of treatment, we talked about permanent pacing. But what if someone comes in, like acutely,
emergent,
to the ER with severe bradycardia?
Right, in the acute setting.
What's our first line?
So often we'll turn to a medication called atropine.
Atropine. Okay.
Atropine works by blocking the effects of the vagus nerve, which can slow down the heart rate.
Right.
So atropine can be very effective at increasing the heart rate.
Like a quick boost.
Yeah, a little boost.
Back up.
Especially in bradycardias.
Yeah.
Originating above the AV node.
Okay, so it's a useful tool.
A tool in our arsenal.
But it's not a magic bullet.
Not a magic bullet.
It doesn't work for every type of bradycardia.
Right.
Especially those originating below the AV node.
Okay.
Like some of the blocks we were talking about.
So we got to know when to use it, when to use something else.
Right. And sometimes pacing is necessary.
Pacing might be necessary.
Right.
This has been a great overview.
It has.
Of the key types of bradycardia.
Yeah.
And how they look on the ECG.
Really important stuff.
But we've got a lot more to talk about.
We do.
I'm excited to dive into part 2.
Me too.
Where we can untack the management.
Yes.
And special considerations for different patients.
Lots to discuss. Welcome back to the deep dive.
I'm ready for more.
So in part 1, we covered the basics of bradycardia, those fundamental ECG patterns.
We did.
But now I think we should really talk about how this all applies in the real world.
Absolutely, because we don't just see ECGs walking down the street. We see patients. And so one area that I wanted to focus on in particular is perioperative management.
Oh, yeah, that's crucial.
Because things can get a little dicey in the OR sometimes.
For sure. The heart can throw some curveballs.
So the guidelines actually have a whole section dedicated to perioperative management.
They do.
And they talk about how it's important to identify those patients who are at risk for bradycardia. Even before surgery.
Yes, absolutely.
Got to think ahead.
Proactive management.
And one thing they specifically recommend is placing those transcutaneous pacing pads on high-risk patients undergoing non-cardiac surgery.
Just in case.
Just in case.
You never know.
Having that safety net.
Safety net.
Right there, ready to go.
Could be a lifesaver.
Like transcutaneous pacing.
Yeah.
You're delivering those electrical impulses through the skin.
Right through the skin.
To stimulate the heart.
That's transcutaneous pacing.
If you need to.
Exactly.
In an emergency situation.
Exactly, when seconds count. Yep. You've got to be prepared.
Like a fire extinguisher.
Exactly.
Okay, what about patients who develop bradycardia or conduction issues after cardiac surgery?
Yes, that's a whole other challenge.
Because they've already been through a lot.
They have.
Their heart is already a little bit...
fragile?
Fragile.
Post-op.
And the guidelines do talk about pacing considerations after various types of cardiac surgery.
After bypass surgery.
Yeah.
Valve replacements.
So it's really helpful to have that guidance.
It's good to have that roadmap.
Now, one area that I'm particularly interested in is TVR.
TAVR, transcatheter aortic valve replacement.
That's it.
Yeah.
It's amazing.
Revolutionary procedure.
It's really changing how we treat aortic stenosis.
It is.
But the guidelines do mention a risk of conduction system damage.
There is a risk.
Or KVR.
Because you're working right near that delicate conduction system.
You are.
So there's a chance you might thump it.
And that could lead to bradycardia.
It could.
And potentially needing a permanent pacemaker.
Potentially, yes.
So close monitoring is key.
Absolutely. Essential.
And they even suggest considering a permanent pacemaker for some patients with persistent left bundle branch block after TVR.
Yes, that's a consideration.
Okay, so TVR, amazing procedure.
Amazing.
But we got to watch those rhythms.
Absolutely.
Now, the guidelines also talk about managing bradycardia in adults with congenital heart disease.
ACHD.
ACHD, that's right.
That adds a whole other layer of complexity.
It does, because their anatomy is different.
Right, their hearts are different.
And so managing bradycardia in those patients can be a little bit trickier.
It can be very challenging.
The guidelines emphasize planning ahead.
Absolutely.
For ACHD patients.
Especially if they're having surgery.
They even talk about placing those epicardial pulmonary pacing leads.
Those leads, yeah.
Intraoperatively.
During the surgery.
If the patient already has sinus node or AV conduction issues.
Right, so you're addressing it proactively.
While you're already in there.
Exactly, one less surgery down the line.
Makes a lot of sense.
It does.
Okay, let's shift gears and talk about acute MI.
Acute MI, heart attack.
Heart attack, yeah.
That's a big one.
Because a heart attack can really mess up the heart's rhythm.
It can disrupt the electrical system in a lot of ways.
In so many ways.
Leading to bradycardia.
Yeah.
AV block.
Other rhythm problems.
All sorts of trouble.
And the guidelines do talk about when permanent pacing might be necessary.
They do.
In that setting.
In the setting of an acute MI.
So, for instance, for patients with an acute MI who develop certain types of AV block.
Like Mobitz type 2,
yeah.
high-grade AV block, alternating bundle branch block,
yep.
or complete heart block.
Permanent pacing is often recommended.
Often, but not always.
But there is a waiting period.
Yes, there is a waiting period.
To make sure the block isn't just a temporary thing.
Exactly. We want to make sure it's not just a fleeting consequence of the MI.
So observation is key.
Observation is always key in medicine.
And they even say that if the AV block resolves on its own, permanent pacing is not recommended.
We don't want to intervene unnecessarily.
Makes sense.
It does.
Now, one last thing I wanted to touch on before we move on.
Sure.
Is the connection between epilepsy and bradycardia.
Oh, yes. That's an interesting one.
It jumped out at me in the guidelines.
So, epilepsy, with those recurring seizures,
right.
It can sometimes lead to what we call ictal bradycardia.
Ictal bradycardia.
Which is basically a slow heart rate that occurs during a seizure.
I had no idea.
It's not super common.
But it sounds dangerous.
It can be, because that drop in heart rate can reduce blood flow to the brain.
Oh, no.
Which can actually make the seizure worse.
That's like a vicious cycle.
A bit of a vicious cycle.
So how do we manage those patients?
Well, the first thing is we want to make sure their anti-epileptic medications are optimized.
Get the seizures under control.
Exactly.
But if the seizures are still triggering bradycardia...
Even with the meds. Then permanent pacing might be an option.
It's like a safety net for their heart.
A safety net. I like that.
During those seizures.
To prevent those dangerous drops in heart rate.
So it all comes back to individualized treatment.
Always.
Considering the whole patient.
The whole patient, their whole story.
Okay, so we've talked a lot about permanent pacing as a concept.
Yeah.
But there are different types of pacing, right?
There are many different types.
It's like having a whole toolkit.
A whole toolbox.
And knowing which tool to use for each patient.
That's the key.
So let's talk about those different pacing options and how we make those decisions.
Let's do it.
Welcome back to the deep dive. We were just about to get into all those different pacing techniques and how we choose the right one for each patient.
Right. It's about having the right tool for the job.
It is, because you wouldn't use a hammer to tighten a screw.
Exactly.
So let's start with CRT, cardiac resynchronization therapy.
Okay, CRT.
When is that our go-to choice?
So CRT is really helpful for patients with heart failure who also have a wide QRS complex on their ECG.
Okay, the wide QRS, that tells us.
That tells us the ventricles aren't contracting in a nice synchronized way.
They're out of sync.
And that can make their heart failure worse.
Got it. So CRT comes in, and it's like the
conductor,
making sure those ventricles are all playing together.
Yeah, getting everyone on the same page.
So the heart can pump more effectively.
More efficiently, improve those symptoms.
Improve their quality of life.
That's the goal.
Now, what about his bundle pacing?
His bundle pacing.
That's a newer technique, right?
It is a bit newer.
And remind us, how does that work?
So in his bundle pacing, we're placing the pacing lead directly into the bundle, which is that specialized pathway that conducts the electrical signals from the atria to the ventricles.
So we're not just pacing the ventricle directly.
Right. We're trying to work with the heart's natural conduction system.
Give it a little nudge.
A little nudge in the right direction.
Instead of taking over completely. Now, there are a lot of different pacing techniques out there.
Oh, yeah, a whole array of options.
How do we keep up with all of them?
It's a challenge, for sure.
And make sure we're choosing the best one for each patient.
So staying up to date on the research.
Yeah.
Reading those guidelines.
Important.
But also talking to our colleagues.
Collaboration.
Especially our electrophysiologist friends.
They're the experts.
They are. They can really help us choose the best strategy.
Now, it's not all about the technical stuff, right? There's also the ethical side of things.
The ethical considerations are crucial.
And the guidelines emphasize shared decision-making.
Yes, absolutely.
When it comes to pacemaker implantation.
The patient needs to be involved.
So what does that look like in practice?
It means we're explaining the diagnosis to the patient.
In plain language.
Clearly, thoroughly.
Talking about the benefits and risks.
Of pacing.
Yeah, and really listening to their concerns.
Listening is so important.
And their preferences.
Because ultimately, they're the ones who have to live with this device.
It's their body.
Exactly.
And sometimes a patient might decide not to get a pacemaker.
Even if we think it's the best option.
Even if it's medically indicated.
That can be tough.
It can be.
But the guidelines are clear.
They are clear.
Patients have the right to refuse pacemaker therapy.
Even if they're pacemaker dependent.
Even then.
Wow, so we have to respect their autonomy.
Absolutely.
Even when it goes against our medical recommendations.
Yes, their choice.
So in those situations, what's our role?
Our role is to support them.
Support them.
Provide the best information possible.
Yeah.
Explain the potential consequences of their decision.
Right.
And make sure they feel heard.
Heard and respected.
Regardless of what they choose.
That's compassionate care.
It is.
Wow, this deep dive has been amazing.
It has been a good one.
We've covered so much.
From ECGs to ethics.
We've really gone deep.
We have.
I feel like I have a much better understanding of bradycardia now.
And how to manage it.
And I hope everyone listening feels the same way.
I hope so too.
So that wraps up our deep dive into the world of bradycardia.
Until next time.
Keep those hearts beating strong.
And never stop learning.
That's what we're all about here on the deep dive.
Absolutely.